So it's really exciting to be a part of the first annual Bladder Cancer Academy, to work with colleagues in this field, both from urologic oncology and medical oncology, to put a comprehensive program together that covers all aspects of bladder cancer management. I think it's been great to be part of this. What's really exciting is just the degree of interest and excitement around optimizing standards of care in bladder cancer treatment, but also a focus on where we are headed in the future in terms of relentlessly approaching new therapies and new ways of treating our patients so that we can optimize patient outcomes. And specifically with regard to novel therapies, we're certainly looking at a huge renaissance in terms of bladder cancer treatment, largely driven by some of the immuno-oncology agents, but certainly have a lot of new other treatments that are currently under development that hopefully will have a significant impact on how we treat our patients. Within the last year, we have seen 5 different agents approved for the treatment of advanced bladder cancer. This pace of development is really unparalleled in any cancer, much less bladder cancer, which for 30 years up until now really hasn't seen much in the way of advancements. Many drugs, a lot of data that we've covered today, but the take-home messages here are that in the second-line setting, the response rate of 15 to 20% that we've seen with these single-agent drugs clearly demonstrates activity in this patient population with durable and rapid responses and a safety profile that seems to be very favorable compared to chemotherapy. And certainly now we have level 1 evidence showing that immunotherapy in the second-line setting improves survival against chemotherapy. And I think this is, signaling a sea change in how we manage advanced bladder cancer. And now more recently, we have 2 FDA approvals in the first-line setting in cisplatin-ineligible patients, reporting response rates in the range of 24 to 29%, suggesting that there's a subset of patients who may never need treatment with chemotherapy at all. What we're increasingly realizing is that patients who have advanced bladder cancer are not eligible for our current standard gold standard treatment, which is cisplatin-based chemotherapy, which to date is the only therapy that's been ever shown to improve survival in the first-line setting. Increasingly, maybe up to 70% of our patients may be ineligible for cisplatin on the basis of significant toxicity concerns. The advent of immunotherapy in this patient population is something that could really signal the beginning of a new treatment paradigm in advanced bladder cancer. And we're seeing that with the 2 new FDA approvals. In terms of where we're headed in the future, certainly much more work needs to be done. There are studies now that are combining novel immunotherapy agents in combination in the first-line setting to perhaps increase the proportion of patients who are responsive to immunotherapy. And also what we're using is now these agents that have seemed to show so much efficacy in the advanced disease setting, we're now testing them in localized bladder cancer. So patients who have had cystectomy for bladder cancer and who are at high risk for recurrence, we're testing these agents in the adjuvant setting. And similarly, we're using these agents in combination with traditional treatments such as chemotherapy and radiation to see if we may potentially be able to avoid cystectomy in this frail patient population. So a lot of activity, much needs to be done, and we expect that over the next 2 to 3 years, we will be rapidly seeing new standards of care develop in bladder cancer care.